Okay, hello everyone and welcome to the Clinical Learning Collaborative for August. My name is Meg and I'll be helping run this webinar. Before we get started, please note that you will be muted throughout the webinar. If you have any questions or comments, please put them in the chat box. This will be recorded and distributed tomorrow. At the conclusion of today's event, please be sure to complete the evaluation that will be sent in your emails. And without further ado, I will pass it to Lindsay Weaver, our Integrated Health Program Coordinator.
Good afternoon, everyone, and thank you so much for joining us for today's Clinical Learning Collaborative. So I have the honor of introducing Dr. Jennifer Feldman. She is the Chief Medical Officer at Centerpoint Health. She is a board-certified general pediatrician and has been the CMO at Centerpoint since 2014. She graduated from the University of South Carolina and Wright State University Boonshoft School of Medicine. She completed residency in Memphis, Tennessee at Le Bonheur Children's Hospital. Thank you so much for joining us, Dr. Feldman, and I'll be happy to hand it off to you.
Great. Thank you, Lindsay. All right. Just going to give it a second for my slides to load up, but thank you everyone who's joining today. I'm going to be talking about childhood immunizations. All right. So yes, I am with Centerpoint Health. We're a federally qualified health center in Franklin, Middletown, and now Norwood, Ohio, so Southwest area. We just recently opened our school-based health center in Norwood. One thing that's a little bit unique about us is that we have a fairly large pediatric population. This has happened for a variety of reasons. When we opened, we were within co-located with a WIC clinic. There's also been some big pediatric practices that have closed around us, and we've absorbed some patients. So we're about 51% pediatrics. So certainly childhood immunizations are important, and as a pediatrician, it's what I spend much of my day discussing. And so excited for a good topic today as we look at the childhood immunizations. You can go to the next slide. Our objectives for today. So first, of course, understanding the rationale for routine immunizations. We're going to look at current trends in vaccine preventable illnesses. I'm talking about immunization recommendations for 2021, both from CDC recommendations as well as for our UDS measures. And then we'll talk a little bit about Centerpoint, our approach to and some tools to improve vaccination rates. Next slide. Next slide. So routine immunization is recommended to prevent 17 vaccine preventable illnesses in infants, children, and young adults. Vaccines help develop immunity by imitating an infection. Vaccines cause the immune system to produce lymphocytes and antibodies. And then once the imitation infection goes away, the immune system is left with the memory. And so when our body encounters an infection, we will recognize that infection and remember how to fight off that disease in the future. This is something you're all aware of and familiar with, but it helps to make sure we talk about that so we can say it in a way patients understand and talk to patients about why we're doing what we're doing. Of course, there's other ways that we create immunity, natural infection being one of those, and that can create immunity on various levels depending on what infection we're talking about. But natural infections also can cause severe complications and can be deadly. So this is true even for illnesses that we think about as being mild, like the chickenpox illness that can still have serious complications, and we don't know who will get those serious complications. And so luckily we have immunization to help create immunity. Vaccines are one of the biggest public health success stories in the United States. Because United States immunization rates are high, many vaccine preventable diseases don't have the visibility they once had, and parents aren't hearing or seeing cases actual disease and the dangers of that. They're also getting conflicting information. We're going to talk about this a little bit throughout the presentation. So the conflicting information that they're receiving. And so that's where healthcare providers come in to provide the level of information that parents need and to keep the vaccine conversation going. I'll say this multiple times throughout the presentation, but it's a really important point. Research shows that parents' most trusted source of vaccine information is their child's primary care provider or nurses. Go to the next slide. So on this slide, I'm showing some of the illnesses that we're preventing. Some may look very familiar because these are pictures that are very commonly used throughout textbooks and immunization presentations you've seen in the past. The top left, you see congenital rubella syndrome, commonly described as blueberry muffin baby. And then we have top right, pertussis infection in an infant, bottom left, tetanus infection, and bottom right, polio infection as well. Go on to the next slide. Here we have some other vaccine preventable illnesses. Meningitis is the first, chickenpox is the second, measles is the third, and of course, finally, COVID is the last on this slide. One resource that's helpful that I wanted to share that I often use for families when talking about their vaccine questions, but also for education for staff and for patients alike, is the Children's Hospital of Philadelphia. They have the Vaccine Education Center, both as an app and as a website. There's some really good short videos on there that are helpful for families. And then they have some trivia games on there as well. And so I was just going to mention one of the trivia questions that I saw on that on one of their games. What famous author nearly died after intentionally exposing himself to a friend who had measles? Mark Twain, Ralph Waldo Emerson, Walt Whitman, or Margaret Fuller? Answer is Mark Twain. When he was 12 years old, during a measles epidemic, he decided to visit his friend who was sick with measles to be exposed. And so this is some helpful ways to bring up different topics about the vaccines that we use and the illnesses that we're preventing. And I can share that those trivia games and that resource with everyone as well. Yeah, and the next slide. Talk about some current trends with immunizations. Go on to the next. So one of the things that's really important to talk about right now is that in 2020, we saw a decline in vaccination rates and vaccine ordering due to the pandemic. CDC reported 14% decline in the number of vaccines ordered in 2020, and it was a 20% in particular for MMR. We saw that vaccines for younger children were being ordered more frequently and vaccines given more frequently. So it was less of a decline than with those older children, the tetanus, HPV, and MMR especially. This was because there was a decline in well child checks and ambulatory visits, and somewhat imposed at times by the medical community and offices, and other times imposed by parents. But now is the time that we need to make up for that lapse and make sure that we're getting kids caught up and aware of the gaps in care. Another reason that this may have happened is schools were not focusing on compliance last year due to the pandemic in some districts, and so that may have led to a lapse as well. Go on to the next slide. So because of this, the CDC had a call to action to help kids safe return to school and get caught up on recommended immunizations, and they recommended approaches from multiple levels to try to address this issue. They recommended that healthcare systems identify families whose children have missed doses and contact them to schedule an appointment. We'll talk a little later about some ways we're doing that using Azara to identify those gaps. Prompt clinicians when these children are seen to deliver vaccines that are due or overdue. And so making sure that you're using every opportunity to give immunizations. And then letting families know that it's safe to come to your office. So what are you doing to keep safe space in, whether that be your waiting rooms or your exam rooms, how you're masking and making sure that families feel safe and comfortable to come back into the office and get their immunizations for kids that may have had a long lapse in care. They also recommended healthcare provider organizations encouraging members to identify and follow up with families whose children have missed doses to get appointment schedules. Next slide. Schools, state governments, and local agencies should also be sending reminders to families about school immunization requirements, following up with families who are not in compliance with the current requirements, and using the state immunizations systems reminder recall capacity to notify families as well. And everyone should always be communicating directly to families the importance of well-child checks and getting caught up on any recommended vaccines that were missed. The World Health Organization identified the reluctance or refusal to vaccinate despite availability of vaccines as one of the 10 threats to global health in 2019. That was in 2019, and I think we are seeing those effects in 2021 very clearly about the impact that can have. As we're looking at our individual patients, I think it's important to remember that vaccine hesitant individuals are a heterogeneous group of people. They can delay, be reluctant, but still accept or refuse some of all vaccines. And so it's not one reason that people are refusing vaccines. It's not one type of person that's refusing vaccines. And it's important to not look when you're talking to these families as deeming them as irrational or anti-science, because that's not always the case. It often reflects legitimate doubts and concerns about vaccines. Making sure that when we are talking about this, we're careful about how we use the word anti-vax or anti-vaccine movement, because it's not always the same as those hesitant families that you have. Most people, even those who are the most critical, do not consider themselves anti-vaccines, and those because of the negative connotations that have come associated with this term. And so just making sure you're cautious as you're talking to people and your fellow healthcare providers. And so recognizing that healthcare providers also have some level of vaccine hesitancy. And we know that a provider's knowledge about vaccines and a way they are able to talk to families is what's going to help families make evidence-based and difficult decisions. And if the vaccine providers themselves are hesitant, then that certainly is going to have an impact on how they talk to families about vaccines. And so I think this is one area that we need to keep working to understand more about where how the community dynamics and sociocultural factors, local knowledge can influence the vaccine decisions of families and vaccine hesitancy. One group in Ohio that's working hard on making sure that we're spreading accurate information is the Ohio Champions for Vaccines. It's a group of Ohioans advocating for vaccines, spreading accurate information about disease burden, safety, and effectiveness of vaccines, and combating misinformation through online advocacy, as well as making sure we're reaching out to our government officials as well. This is something that will, I think, over the next, it's actively something we need to be paying attention to right now, but it's also going to be something in the coming years that's not going to go away. And so making sure we're thinking about vaccine hesitancy in a looking at all the factors at once. Currently, there's a bill out, and hopefully you've heard some about it, House Bill 248, which was looking to prevent, it was sold as it was looking to prevent the COVID-19 vaccine from becoming mandatory. But the bill actually applies to all vaccinations, including childhood immunizations, and could really impact how our schools and employers are able to encourage vaccination. I had asked this morning, and it looks like it's going through its sixth hearing next week, and not scheduled for a vote at this time, but keep an eye out on things like that to make sure that you can have a voice and advocate for the safety of vaccines, because just like you are that trusted source of vaccine information for your patients, we need to be that trusted source for vaccine information elsewhere as well. Next slide. All right, so I'm going to go through now the immunization updates and recommendations for 2021. All right. Here is the recommended vaccine schedule from CDC, and this is updated each year. Something important to make sure that you're paying attention to any changes that come along with it, and that if you have these posted throughout the clinic, that you update them regularly as things do change. This year there weren't too many big changes, but it gives you the range of when doses can be given. And when they're recommended. And so that yellow range is or the yellow color on the schedule is the recommended ages. And then it has the catch-up is that green color, and purple is the certain high-risk groups may be recommended for vaccine at different ages. And go on to the next slide. Specifically for 2021, there were a couple of small changes. So for tetanus update, they updated the special situation for wound management that we're going to be recommending for minor wounds for kids under 7, or I'm sorry, for all wounds for kids under 7 except minor wounds. It's recommended to have a DTaP if it's been 5 years since the last tetanus, and then for kids older than 7, it's 10 years if it's a clean and minor wound, and 5 years if it's a for all other wounds. The Haemophilus influenza was revised for catch-up, just stating that there's no further doses recommended if the last dose was administered at 15 months or older. The Hep B clarified the recommendation for birth weight of less than 2,000 grams, which would mostly be dealt with in the hospital for these infants that we are, if the mom is hepatitis B antigen negative, all babies are going to be getting a dose within 24 hours if they're greater than 2,000 grams. If they're less than 2,000 grams, then you're going to wait till 1 month or at time of hospital discharge. Okay, next slide. The HPV note was updated to recommend that if vaccine schedule is interrupted, the series does not need to be restarted. For influenza, the egg allergy special situations was updated. So if you have hives, we recommend any influenza vaccine appropriate for age and health status annually. If you have egg allergy with more severe allergy, such as angioedema, respiratory distress, or need for epinephrine. These vaccines are still recommended, but should be done in the setting under the supervision of a healthcare provider who can recognize and manage severe allergic reactions. The meningitis update for MENQAFI, it's an additional option for meningitis ACWY, and it's just updated the special situations for the minimum age for MENQAFI is 24 months. And remember, this is not a routine recommendation at this age. It's only for special situations. Such as anatomic or functional asplenia, including sickle cell, HIV infection, persistent complement component deficiency, or complement inhibitor use. Otherwise, it's recommended at age 11 and 16. Next slide. The as you're talking with staff and providers alike, making sure we're talking about how to recommend, how to have these conversations. And the first step is to assume parents are going to vaccinate. Give your informed consent, and if parents consent with no further questions, then administer vaccines. If parents are not ready to vaccinate, give your strong recommendations. And if they have specific questions or concerns, then make sure we're listening to and responding to those concerns. I find it helpful to listen to ways that others are recommending certain things, and CDC has a good set of videos they've put out on different providers and how they're recommending certain vaccines. And so I was just going to play a video for you that on the next slide.
When I recommend preteen vaccines, I recommend all 3 of the vaccines that we intend to do the same way, basically. So here are 3 vaccines that we want to do. I do give a little bit of information about each vaccine because that's my informed consent, just like when I talk about infant vaccines. So I can talk about all 3 preteen vaccines in about a minute and have my informed consent done at the same time, and kind of avoid the too much information thing. So this is how I present things to parents. Today, there are 3 vaccines that I'd like to do. The first one is the meningococcal vaccine, which prevents a very, very rare but potentially very serious infection that could cause meningitis. And when it does, it's uniformly devastating and potentially really deadly. The second one prevents the HPV infection, which is extremely common. In fact, most of us get HPV in our lives and can go on to cause multiple different forms of cancers. That vaccine is given in a series of 2. The second one would be given 6 to 12 months from now. And then the last one is the one that most people know about. That's the tetanus booster, or the Tdap, which vaccinates against tetanus, diphtheria, and pertussis, which is whooping cough. If your child gets whooping cough, they could have a bad cough for 2 or 3 months, which is not fun, but really the big reason that we vaccinate big kids and grown-ups against pertussis or whooping cough is to protect babies who could die from that. Do you have any questions about those? Usually parents don't. About 80% of parents say, okay, that makes sense.
Thank you. So yeah, that one's an important one. I think because HPV is one of the commonly declined vaccines that we see in that adolescent age group. And so thinking about your technique as you're having these conversations with families is important. And another one that is in the same realm that we got to think of the questions that we're going to be receiving is, of course, the COVID-19 vaccine. So CDC recommends everyone 12 years and older should get a COVID-19 COVID-19 vaccination to help prevent against COVID-19. Right now, Pfizer is the only vaccine approved for that age 12 to 17. There are current trials for younger ages down to age 5. The last I read is that they were thinking maybe September for Pfizer being younger and Moderna by December. But I mean, I think there's we got to kind of watch and see what comes out. They asked for expanded participants and additional participants due to to monitor for side effects, specifically myocarditis risk. If you want to go to the next slide. So myocarditis is very rare, 40 cases per million on the second dose in males aged 12 to 29. And that's where we're seeing it the most. It's only 2.4 per million dose per million on the second dose for ages over 30. And so we need to make sure that we're talking to families or answering questions for families when this does come up, and that we're able to look for signs. So the benefits of vaccinating all recommended age groups with COVID-19 mRNA vaccine clearly outweigh the risks of the vaccination, including the risk of myocarditis after vaccination. But they're going to continue to monitor outcomes of myocarditis cases, and providers and public should be informed about these cases. So next slide. This goes through the 2021 updates for the UDS measure. So the UDS measure for childhood immunization looks at the percentage of children 2 years of age who had the following by their second birthday: 4 DTaps, 3 polios, 1 MMR, 3 to 4 HIVs, depending on the series, 3 hepatitis B, 1 varicella, 4 PCV, 1 hepatitis A, 2 to 3 rotavirus, depending on the formulation, and 2 influenza. The denominator when they're looking at these this measure is children who turned 2 during the measurement period and who had a medical visit during the period. And next slide. Now, when we look in, there's no exclusions for this measure, I think, except hospice care. But instead, there are ways to make sure we're including in the numerator patients who have either had infection in certain cases or had a particular type of anaphylactic or particular type of reaction, such as anaphylaxis or an adverse reaction. And there's some specifics here. I'm not going to go through the details on all of those, but making sure you're paying attention to how that's counted, and it's coming. We're including these patients in the numerator instead of taking them out of the denominator, and making sure that you have a way to document that as we're tracking these numbers. Next slide. All right. In this last section, I'm just going to go through some tools that we've used to help with our vaccine rates with this UDS measure, but also with our vaccination rates in general. So the next slide goes over, the most important thing that I've found that's helped our organization is using every opportunity to vaccinate. And this means giving vaccines outside of well-child checks. On our process for pre-visit planning, we have a daily huddle, and during that time we discuss the immunization status of every patient that's scheduled. We do this using the pre-visit planning tools from Azara, but also in our EHR, and I'll show you some of that in a second. Another thing that's helped us is having an interface with our EHR and Impact Sys, and that's a bi-directional, and so we get information from Impact into ECW, which is our EHR, but also when we give immunization, that goes directly to Impact Sys. Next slide. So this is an example of what a patient on our pre-visit planning tool from Azara would look like. And it shows you which childhood immunizations are due. And we have the support staff as they're preparing the pre-visit planning tool for huddle the next morning. Look at the EMR and make sure when they see there's this many missing, is it because we don't have records yet? Is it a family that's previously declined, so that we can discuss? Okay, go to the next slide. And oftentimes it's if it's a new patient, especially, it's because we don't have the immunization records into our EMR yet. So this is an example of how we can pull over the data from Impact Sys directly into our EMR by just, it will ask you to, the step right before this asks you to verify that this is the correct patient and date of birth. And then it will show up what is showing currently in Impact Sys, and you can bring it over into the patient's ECW record. And that's what will trigger Impact or Azara to say if you're up to date or not, but also our ECW to say if they're up to date or not. This is a example of the Azara report for the UDS measure for childhood immunizations. And if you notice in the bottom right, it gives you a comparison to other health centers in Ohio. You can also see the gap reports, and that's what we use a lot as we're reaching out to see who we need to get caught up on immunizations. Is using this report for the young ones, but then there's a similar report for older kids as well. Next slide. And so we can do this outreach to patients either by calling, and we have some UDS champions that we use within the organization, which this year, I'll be honest, has been a little more challenging because of our current staffing shortages, but the goal is to, when we have openings in our schedule, that we're reaching out to patients, or as we're trying to anticipate who's going to become due for immunizations if they've not been scheduled. There are other reports in Azara to look at, and I've listed them here. These also, so the adolescent immunization measure looks very similar to the UDS measure for the younger UDS measure, but it's just for those adolescent immunizations. But you can also look at immunizations management tool, which gives some good information there as well to identify those patients that need outreach and appointments. Next slide. And there's a further breakdown when you look at that Azara report, which I found interesting and wanted to share. So this is looking at that 2-year-old measure for UDS, and the areas that we have found more difficult to be compliant with this measure is flu vaccine. And you can see that here when we look at which measures are compliant. And that's because of mostly because of refusal, that parents may be willing to give every vaccine except flu vaccine. And then the rotavirus vaccine, and that one's due to the timing of the vaccine, that the schedule for rota is a lot more specific and does not allow for the same catch up that other vaccines do in their schedules. And so if a child misses their 2 or 4 month old well child check, then it's hard to get them caught up because of the recommendations there. Next slide. One of the things that is really important in improving vaccination rates is making sure that it's not one person that's recommending vaccines to a patient. It doesn't just come from the provider, but that we have a whole culture of immunization. So making sure our support staff has good knowledge to be able to answer questions and to have a give a strong recommendation and a positive look on vaccines. We use training through CDC for our onboarding, as well as annually with the You Call the Shots training videos, as well as the COVID vaccine training modules. In the past, we've used Ohio AAP trainings with the MOBI and TIES training programs. MOBI is maximizing office-based immunizations. And I think it's been a few years since we've done a MOBI training for our staff. I think in 2020, they started doing this virtually. But it used to be an on-site training. And then we also do clinical skills trainings with staffs giving injections at hire and annually. All right, and the last thing that we've done that's helped and will help more in the future as well is that we've started using AccuVax. It's a system that's for vaccine storage, refrigerator and freezer both. It includes the patient information and has decreased some common errors. It also has the continuous monitoring that you need for VFC program, and so you can report what you need to for VFC, and it's got a built-in battery backup. It's also going to help us with being able to separate the private stock vaccine with VFC vaccine. So right now, we only offer vaccines for children immunizations, but in the coming months, we will start being able to offer vaccines for commercial insurances as well, which will hopefully improve our vaccine numbers and in another way. And then, yeah, that is everything. Any questions? I saw some questions come up in the chat.
Yes, thank you so much, Dr. Feldman. So I'll read off a couple of questions. So how did you develop the interface between ECW and Impaxis? Can any office do that to facilitate entering immunization data into Impaxis more efficiently and not having to do so with duplicative or double entry?
Yeah, and so that's something, we were one of the pilot programs when they first opened it, but now is available for anybody. I think you just have to talk to Impact for them to connect with ECW to make sure it's activated in your program. And I know that's true for other EMRs as well, but I don't know specifically which. But I would start with reaching out to your Impact contact, or your VFC coordinator can get you in touch, because it's definitely been a huge help for efficiency and accuracy, that we're not doing duplicated immunizations that aren't needed because we don't have a shot record, those kind of things.
Awesome, thank you so much.
Mm-hmm.
Do you allow alternative immunization schedules to be used if the patient's family have hesitation to receive so many immunizations at once?
Absolutely, yeah, and this is a question that I think is coming up more often lately, of course, I strongly recommend staying with the CDC schedule, and I talk to families about why we recommend the CDC schedule and how things have been tested and studied that way. But if they're not willing or they have certain hesitancies, then I think meeting them where they are and protecting against the things that we can protect against. We also don't have any policies that don't allow patients who are unimmunized to come into the office or practice, as far as they have to go somewhere else if they're not going to get vaccines. The reason for that is that I think that some families won't get care elsewhere if no one is accepting patients that don't get vaccines. And so this is something that some practices around us have done. And I don't think that it's going to increase immunization rates. It's going to just decrease well child checks and other preventive medicine for certain families. And then I've also seen plenty of not plenty, but some families that have after many conversations and continued conversations that they do decide to get the vaccine or a catch-up schedule.
Yeah, that's an excellent point. Thank you. A couple more questions coming in. Dr. Dana asked, one issue I have had in the past is lost opportunities at visits due to being out of a particular vaccine from an inventory standpoint. Can you discuss how you manage vaccine inventory?
Yeah, so we do, our goal is to order every 3 months and we do inventory monthly. This has been, now that we're switching to the AccuVax system, it does alert you sooner when you're getting low on vaccine. And so, that's been helpful. But this is something that we are still working on as well. And we're actually working to hire an additional part-time person who's going to be helping us with inventory at all 3 sites. Right now, it's a duty that we're splitting between some of our team leads and nurse managers, and because of staffing, that it's not been as consistent. So we are looking to do this. And the other thing that pushed us in that direction was managing the inventory for COVID vaccine, and for this person to be able to do COVID outreach as well, for second doses and community outreach on that. So we'll let you know how that goes.
Yeah, that would be great, Dr. Feldman. Thank you. So Dr. Dana also expresses her appreciation. Another question, I'm also curious about the ratio of MAs to providers, since immunizations can be time intensive for nursing staff.
Yeah, so our goal is to be 2 to 1 for providers. We went up to that higher ratio when we switched to team care medicine. So yeah, our goal is to be 2 to 1, but we're having shortages right now, as I know many other places are.
Thanks, Dr. Feldman.
Mhm.
So while we wait on more questions to come in, I do want to share some clinical guidance that we developed last year. We developed some clinical guidance on the state bottom 4 measures from the UDS clinical measures. So this first one that will pop up in this document is actually from the childhood immunizations UDS measure. And a lot of this guidance came out of one-on-one conversation that we had with Dr. Feldman, who's kind of briefly going over some of what she discussed today. So just want to lift that up for those of you who want to take some actionable steps following up with today's webinar. This is a really great resource that could not be possible without Dr. Feldman's input.
Thank you. And I probably should have looked at this again before I put this slide together, because I forgot some of the things that we had talked about there as well.
Oh no, don't worry about it.
Well,
don't worry about that at all. I'll make sure that this document gets sent out in follow-up as well. So if you're listening via phone and you can't access the chat, we'll make sure that you get this in follow-up.
And Lindsay, this is Dr. Dana. I would just chime in that in hot off the presses, reviewing and looking at state comparisons for the 2020 UDS performance, we continue to struggle with childhood immunization, and it is one of our 2 measures that is in the bottom quartile still. So I think anything or any ideas from you all about what you need or what would be helpful, we would certainly love to hear, because we really this next year want to see what we can do collectively and at our individual health centers to work on some continued performance improvement. I know this is a tough measure just because there are so many variables involved in getting it to come into compliance. But please let us know if you have ideas for trainings or webinars or resources that you think would be helpful to you.
Great. So I guess if there isn't anything else, we can end a little bit early. Any questions, like Dr. Dana was saying, you can send over to us and we can help answer those for you. And if everything's okay with you all, we can go ahead and end this webinar. And thank you all for joining us, and thank you, Dr. Feldman.
Absolutely. Thank you.
Have a great day.